All right, guys, welcome back. We're here today to talk about some of these degenerative diseases of the nervous system. And let me just kind of go through here and run through your learning outcomes. Okay. Yeah. Okay, here we go. So a lot of the diseases that we're going to talk about today there is no cure for them. Instead, what we do is we just kind of slow down the progression, control the symptoms, and to try to get them to a level of normalcy so that they can eat, feed, bathe, clothe themselves. A lot of these diseases are going to end up in a hospice kind of an assist scenario. So having an understanding and having that conversation early on kind of helps it to sink in a little bit, a little deeper, so that our families understand where we're going whenever we give one of these diagnoses to them. So the first one we're going to talk about is Parkinson's disease. And Parkinson's disease really came to the forefront whenever actor Michael J. Fox came out and began to describe his issues that he'd had with Parkinson's disease. I'll tell you that Michael J. Fox is not the standard case for Parkinson's disease. Most of the time we see Parkinson's disease in male patients, okay, that makes him standard, but normally we don't see it in his age. He was actually diagnosed at the age of 29, which is really, really rare. Typically what we see is we'll see patients come in their late 50s, early 60s with some of the symptoms. This is kind of what we look for whenever we have patients that come in with Parkinson's disease. They got this pill rolling behavior. They kind of move their hands all the time, and they maybe do a little twitching. And then when they walk, their heads are kind of down, and they kind of shuffle their feet a little bit. If you've ever watched the Carol Burnett show a long time ago, there was a gentleman on there by the name of Tim Conway, and Tim Conway was notorious for mimicking the patient with Parkinson's. So go to YouTube, look up the Carol Burnett show, look up Tim Conway, and look at his videos of him playing a Parkinson's patient. Very, very slow moving feller. Loss of normal arm swing. Again, you can see these patients, guys, after you've seen one or two of them, you can go to the mall and watch for these patients. You can sit in Walmart and you can see these patients walking around. Very interesting patients, but they do have some very distinctive movements. Again, typically after age 50, very slowly progressive, and typically in the male population. This is kind of a jumbled mess, but just go with me here. So what happens in these Parkinson's patients, is that they get an imbalance in their brain between dopamine and acetylcholine. They don't have the right amount, like the dopamine in their brain is just not being produced in enough amounts to balance out the acetylcholine. So the acetylcholine making them keeping them going, and the dopamine can't stop because there's not enough dopamine there to balance out the brain. So these patients have a deficiency in dopamine in their brains. You would think that the easiest thing to do would just be to balance them out. You're like, hey, Miss Hardy, we give dopamine all the time in critical care and other places. Let's just give them some dopamine. The problem is the dopamine that we have currently in that chemical form does not actually cross the blood-brain barrier. So we have to give a different type of drug in order to get it across. We also want to restore enough function to promote activities of daily living. Eat, sleep, feed, bathe themselves. That's our goal. So we have two different types of medication, well, technically three, if you really think about it. We have two different ways that medications act on the brain, three different ways that medications act on the brain in order to keep the patients, to get them the dopamine in the brain that they need. We have dopamine agonists, which help to stimulate the dopamine receptors. And then we also have this dopamine kind of protector called entacapone that is helps to prevent dopamine from actually being broken down. And then also we can use anticholinergic drugs. Let's talk about each one separately. This first one that we're going to talk about is levodopa/carbidopa. Now, levodopa, okay, goes to the blood-brain barrier, and if it can get across the blood-brain barrier, boom, it turns into dopamine. The problem is that the body knows what's up, and the body's like, you are not supposed to be here. So what happens is carbidopa, its best friend, talks to the blood-brain barrier. It's like, listen, buddy, I know you're upset that this guy levodopa is trying to get in, but I just need you to go in. And he actually provides enough of a distraction that the levodopa can crawl through the blood-brain barrier, get behind enemy lines, boom, take off its leva, and just become straight up dopamine. Now we got more dopamine hanging out in the brain because its best friend carbidopa sacrificed itself at the beginning of the blood-brain barrier. It really is an amazing story. Carbidopa, you will always be, in my book, a true hero. We do have extended release versions of these, which is great. That way we have a really long acting ones. I will tell you that the short acting ones, they tend to work a little bit better. They don't have as much on and off phenomenon if you can get them timed just right. You got to be careful with them though. The extended release form is great if it works, but sometimes it doesn't always work because it gets into trouble with some of the other medications that are going on in the body. Because typically these patients, by the time they're over 50, we have cardiovascular issues, renal issues, and liver issues all going in with that too. These are some of the adverse effects that can happen with these patients. When remember, if the patient's not sleeping well, the anxiety level is going to go up. So if this medication is causing sleep dysfunction, it's going to make a lot of the mental health issues a lot worse. So we need to make sure we're watching for these patients. These patients need to be instructed by their family when they take them home that this medication initially will cause orthostatic hypotension. I don't need any 50-year-old people falling out on the ground, laying down and breaking a hip. Okay, especially not when we already have Parkinson's on top of it. So change physicians very slowly. It can actually cause dystonia, dyskinesia, can cause more issues sometimes than it's fixing. So again, we have to watch these patients. We have to help explain to the caregiver about proper medication administration. This is not a medication that we want to give at 2 o'clock, 3 o'clock in the afternoon because it's going to keep them up all night. So got to work with that. Also, difficulty concentrating and confusion, helping the family to understand, whoever that person's caregiver is, that when we first start taking this medication, things are going to get worse before they get better, okay? And that they may need help with reminders to take their medications, reminders to eat, because their brain's going to be really, really foggy when they first get on this drug. Here's some of the more of the severe adverse reactions. Remember that neuroleptic malignant syndrome? This is where they get this really, really high temperature and we don't know why. It's because their brain's tripping on something. Again, at granulocytosis, basically anything in their bodies, their white blood cells, their red blood cells, it just kind of clears them all out. These patients can have an increased risk for suicide, so we have to let that family member know that when we're starting treatment, if you begin to see that they're talking more about death, concentrating more about death, talking about a plan to kill themselves, we need to know. Extrapyramidal side effects can be anything from tardive dyskinesia to the pill rolling. So some of these Parkinson's movements that they were doing can actually get worse. This medication does come out in the liver. It's metabolized out in the liver, so it can cause liver injury. So watch for those patients. If they start to talk about nausea, vomiting, yellowing of their sclera, yellowing of their skin, we might need to bring them back in and do some additional lab studies. These medications don't play well with some of our other stuff. If you give a patient vitamin B6 and the levodopa cardopa, you just negated it. The B6 is like Pac-Man. It finds the carbidopa, levodopa, eats it, and completely and totally disintegrates it. So don't do that. Anticholinergic drugs, because these medications kind of cause some of the same side effects, it'll make those anticholinergic effects even worse. So we try not to pair them together unless we absolutely have to. These medications are great because they quickly, like you'll give a patient their Parkinson medicines, 30 to 45 minutes later, you know, they were in there and then all of a sudden you give it to them and they're better, okay? But as that dose goes to the end of the day and it begins to wear off, all of a sudden those symptoms are going to come back. Unfortunately, over time, the patient will develop tolerance to the medication, meaning that eventually this dose isn't going to work. So we titrate to the smallest dose possible to control the symptoms, knowing that we're going to have to go up and that eventually we're going to get to the point to where the medication may or may not be effective at all. Always want these patients to take them on an empty stomach for the best absorption possible. If you eat it with a high protein diet, the medication's therapeutic effects are going to be reduced. So we want the patient to take it on an empty stomach. That's the best way. Also let them know that it can darken their urine and darken their sweat. Again, as someone who's a family member of these people who may be helping them to care for them, if you didn't tell them, hey, by the way, that urine is going to be more amber or darker than normal, then they may think that the patient either needs more fluids or something else is going on. So make sure you notify the family member. Also, skin lesions. I don't know if you've seen little old men in a while, but you should really look at them. They got some funny spots, funny looking spots. some of those funny looking spots are probably not all benign. You know, maybe it's a basal, maybe it's a squamous, but sometimes those funny looking spots, when we start giving this medication, get even funnier looking. And it can be malignant melanoma. This medication can actually activate it. So what was just a little small dab of melanoma turns into a huge problem with malignant melanoma. So watch their spots, okay? Important that we do a good, thorough skin assessment on these patients before we start the medication, looking at all their little folds and thinking about where that malignant melanoma is most likely to be targeted, or most likely to show up if it was going to. This medication, known as Comtan and Entacapone, that's what we're going to say, Entacapone. It sounds like Al Capone. Entacapone is really kind of a cool drug to be paired alongside of levodopa and cardopa. This medication actually has an effect. Do you remember when we talked about our mental health medications, we talked about MAOIs? Well, MOAIs, an MOA, monoamine oxidase, is responsible for breaking down the monoamine oxidase in your body, right? Well, what this medicine does is that it prevents the MOA, the monoamine oxidase, from finding the levodopa and the carbidopa and attacking it and making it degrade. So this medication kind of stands as a shield. So if the cardopa is busy making the border patrol look the other way, then this guy is standing behind the cardopa with a big shield so that the MOA can't even get to it, so it can't break it down faster. So it helps to keep the levodopa and the cardopa around even longer in the system so that the MOA snipers can't take it out. The other thing you'll see us use for our patients who have Parkinson's disease is anticholinergics. So the anticholinergics can be useful in helping to decrease some of the tremor and the rigidity, but not necessarily the bradykinesia, not the slow ones. We tend to find that these are better tolerated in our younger persons. So I'm sure that Michael J. Fox probably had some treatment with some anticholinergic medications before he got on the other drugs. Because these side effects of these medications have anticholinergics. So remember what that means? They're going to have dry eyes and dry mucous membranes and can cause urinary retention. And any patient over the age of 50 does not need to experience urinary retention because of potential benign prostatic hypertrophy. All right, Alzheimer's disease. So I have a movie that I think you should watch. The movie is called Still Alice, and it's either on Netflix or Amazon Prime or one of those. So Still Alice is the story of a young lady who developed early onset Alzheimer's, again an atypical case of Alzheimer's from a familial genetic component. Very interesting movie. Take a box of tissues. It is a tearjerker, but it's a good movie for you to watch in relation to Alzheimer's, and it's a true story. Here is what we see are A's of Alzheimer's. They forget what things are. They misplace their objects. They begin to forget familiar items, familiar things. They don't know who they are. They don't know who you are. And then they lose the ability to actually talk for themselves. This patient will progress. Again, the medications that we're giving them is not going to stop this disease. The medication that we're giving them is going to keep them from progressing as fast as they possibly could. We do have some non-pharmacological interventions to talk about with this type of a patient. They say that for those of us who are not prone to Alzheimer's, like there's two different types. There's a genetic type, and then there's just the type that you can get because you're getting old. If we eat a good diet, as I drink my Coke, exercise 3 times per week, 30 minutes a session, and maybe even take a little vitamin A supplementation following the Mediterranean diet, that they can actually decrease the incidence of, decrease your chance of having Alzheimer's. I feel like following these two recommendations at least, you could also prevent cardiac disease, diabetes, high cholesterol. I mean, there's lots of things. So we need to clean up our diets. Someone once told me the best way to eat your food is to eat from the outside of the store. And you know, you think about it, when you walk into H-E-B on the market side, what's the first thing you encounter? Fresh fruits and vegetables. When you walk into Walmart, what's the first thing you encounter on the market side? fresh fruits and vegetables. Okay, the only one who hides their vegetables is Kroger's in town. I don't know what that is. But again, if we were to eat more fresh fruits and vegetables and eat like we're supposed to and exercise like we're supposed to, we could prevent a lot of these chronic diseases from occurring in our system. Of course, we are always going to have bad genes. Thank you, Mom. So the goals of Alzheimer's is to improve your symptoms and to prevent decline. We want to keep these patients healthy and on their good foot and stimulated for as long as they possibly can be. It is very hard to scale a mountain, but if you start scaling a mountain when it's just a hill, you can do it. So you have to start early and you have to think about how to preserve their independent function as long as possible. We have a couple different medications, two different types. One's a cholinesterase inhibitor and the other one is N-methyl D-aspartate antagonist, which is the reason why we call them NMDAs, which I also thought was genius of whoever developed the nomenclature for this one, because they, the shortened form is NMDA, and then the drug's name is Namenda. Very, very clever chemist. Let's talk about those cholinesterase inhibitors. They're going to prevent. So, in our Alzheimer's, in our Parkinson's patients, we were all about, hey, we need to get some dopamine going in here. Well, with our cholinesterase, with our Alzheimer's patients, it's all about keeping that acetylcholine around. We think better when we've got more acetylcholine around. So for these patients with mild to moderate symptoms of Alzheimer's, we can start medications like Aricept, the Donzepel, those sort of things. The only kicker is, remember we talked that some of us are mutants? This medication is specifically metabolized by a P450 enzyme. And what that means is that if you have an overactive P450 system in your liver, and you're only going to know if certain drugs don't work for you, then this medication may not help you at all. So if they have a patient who has Alzheimer's who's not receptive to therapy, sometimes they will go ahead and pull the genetic testing on them to see whether or not they've got this particular chromosome abnormality or not. You can see the side effects here. Again, we have to convince the patients that these side effects are actually worth it in order for them to continue to take them. These medications don't play well with our first generation antihistamines or our tricyclic antidepressants or our other antipsychotics. The good news is these medications do have a long mechanism of action. So once per day dosing is possible, which is great because then we only have to remember to do it once. We do need to worry about titration because we got to titrate up till it's beneficial. And then as long as the side effects are tolerable. Just because you aren't getting the results you want doesn't mean that you keep going up on it if the side effects aren't worth it. I don't want to fight with anyone. I'm sure the caregiver doesn't either. Here's the NMDA, also known as menetamine or Namenda. This medication actually serves as a bouncer, for lack of a better word, lack of a better explain this, for calcium. So whenever extracellular glutamine is low, it blocks the calcium level. But whenever it permits calcium influx into the cell when the extra glutamine is high, so it's sitting there and it's like, you can't come in, you can come in, you can't come in, you can't come in. So it's kind of like a bouncer sitting at the door. This medication, again, can cause some of the same side effects as our anticholinesterase inhibitors, and it does interact with some of the medications like amantadine, ketamine, and sodium bicarbonate. The amantadine I put on here because I wanted to bring that my attention to you because you can't have a patient who has the worst genetic luck in the entire world or the worst luck in the period and can have Parkinson's and Alzheimer's at the same time. Amantadine would be one of those medications that you would see that they would take on a frequent or could be taking to treat their Parkinson's disease. So just to put that as a, oh, okay. Ketamine is a drug that we use for like sedation type purposes. So if you had a patient who is going in for a procedure of some kind, you want to make sure that they're not using ketamine. And then sodium bicarbonate, that would be like, we give that when in ICU a lot to help to change the electrolytes around. So if you're given that, it may make the metamine not as effective as it possibly could be. Again, we need to titrate up to effectiveness and for as long as the side effects are tolerable. Multiple sclerosis basically inflammatory disorder, eventually the body's own immune system begins to attack its the myelinous layer of all the nerve endings. So multiple sclerosis is kind of tricky because the patient goes through these batches of like, oh my God, what's wrong with me? I'm fine. Oh my God, what's wrong with me? I'm fine. Eventually what happens is that the body's autoimmune system does kind of break down on itself. It eventually leads to long-term damage of the neurons in the patient's body. And I would love to say, oh, well, it's always their right leg that becomes weak. No, it's a really fun disease because you don't really know where it's going to strike next. So they may have had a visual disturbance with their first episode, but now their second episode, it's their right arm has gone numb and tingly. But then they recover from that, and now it's the left leg is hurting. So kind of a weird kind of a diagnosis to have to try to capture. The good news is we do have treatments for these patients. You might see a patient on a corticosteroid like prednisone, decadron, dexamethasone, methylprednisolone. They may be on a cyclophosphamide, which is a cellular medication that helps to prevent some of the cellular damage. And then maybe even taking some intravenous immunoglobulins or giving themselves shots on a weekly, monthly basis in order to help to control their immune system. The other weird thing that you'll see with this one, not so much of a medication, but it's plasmapheresis. They'll actually go in, take the patient's blood, remove the crappy antibodies, and then push the blood back into them. You see a lot of immunosuppressant therapies, and then sometimes you'll have to do some targeted symptom management depending on what's going on. These patients can have like constipation one day, then it's diarrhea. They can have peeing on themselves, and then they have urinary hesitancy. It depends on how the nerves are being affected as to what's going to be the symptoms that they need the most help with. All right, guys, that's everything I got for you about degenerative nervous system diseases. All right, guys, talk to y'all soon.